in my research institute, we usually have the opportunity to get a pre-market release, so a limited market release where we are one of the first. So from the first day on, we were using the lens, and especially the toric version. I think I was the first one in Germany using it. And from the first day on, we had excellent outcome. RayOne EMV and RayOne EMV Toric are not diffractive lenses. They are refractive lenses. It uses the concept of inducing spherical aberrations to induce a more deeper depth of focus effect. They use 100% of light to do that, using 100% of the incoming light, not splitting it like a trifocal lens to like 30% for the near and 30% for the distance. You have a much better contrast and much crisper image compared to some of the other premium lenses. The fascinating thing is that with a slight amount of monovision, half a diopter, 1 diopter, you get up to 1.5 to 2.25 diopters of depth of focus, which is very competitive to classical EDOF or even trifocal lenses. But you don't have this on the expense of losing vision quality, and that is the important part here. The normal cornea has some positive spherical aberration, and a lot of companies try to compensate that with an intraocular lens. With that, you narrow very much the depth of focus. And the EMV has a built-in enhancement of spherical aberration. They induce positive spherical aberration, and with this, they increase the depth of focus. And this is a natural type of increasing the depth of focus because our optical system is used to it. And so with this is kind of disruptive technology in terms of creating a non-diffractive technology without rings, without halo glare, stuff like this, and still getting the patient to a point where he can get good intermediate and even reading acuity. Yeah, when you look especially also at the toric version of it, you have to say that they really take advantage of the long development of the platform. When you look at the EMV lens, you see this kind of closed loop haptics, which I attached to it. And this is a specific haptic design which prevents decentration and rotation. When the capsular bag is shrinking, it kind of stays exactly at the same position. We already saw that in the previous models and could show that also with the early toric versions, that this is a spot-on, very safe and stable situation. And this is what you need if you want to take advantage of the specific optic, which gives you better depth of focus. The other thing is the lens is very smooth. So guiding it around the capsular bag is very easy. You don't need to fear that you will damage the capsular bag if you have to do some corrections. The closed loop haptic has the advantage that after a couple of weeks, lens epithelial cells grow through it and really fix it in the right position. So you won't have any kind of late decentration or late rotation, which this is very, very advantageous. It is an interesting concept to look at the very first lenses that have been implanted in several countries, because at that point, normally, we don't have 100% optimized A constant and stuff like this. But the interesting part was that all these centers that started with it had excellent outcome. So there was no learning curve, there were no outsiders in terms of outliners, in terms of the values. And of course, you look for the ideal patient and have good outcome normally. And everything paid off. Everything really developed like this. And the outcomes were very comparable between the different countries or the different surgeons. For a first release, it's very interesting, and it's encouraging for the other doctors that follow that somebody has tried it, come out with good results, A constant is good, reliable, then the next wave of surgeons can use it and can be sure that they won't have any issue. The spherical aberration is something that changes over age, and that is an individual factor of every patient. And when we look at, let's say, data from several hundreds of patients, we do some studies, normative data study with the Pentacam, we see the variation and also how it changes over time. So there is some variation in it anyhow. which gives you the confidence that the lens is also very forgiving. IOL calculation is if you are a little bit off, half a diopter, don't worry, you still get the 20/20 outcome. You may lose a little bit of near, but nevertheless, you have the, I call it the parachute landing zone, where you can land, and this is quite good for the surgeon. The extra forgiveness gives you an increased profile of patients who can adapt the technology to. So if you have a patient where the measurements were difficult, who is a dry eye patient, who has previous corneal refractive surgery, you like to have an implant that has some kind of forgiveness. This extra half a diopter can make the difference between a happy patient and an unhappy patient. And therefore, all these lenses that enable a certain range of forgiveness are very, very much appreciated. On the one hand, the surgeon can use this in uncertain cases. On the other hand, he can use this range he has for an algorithm or a normogram to create mini monovision or other things in order to get the full range of vision. So he can use it in both directions. Normally, when we look at the data we get also from the big societies, we have to say that only 60% of the average surgeons get plus minus half a diopter to where they targeted. So 40% are off their target, and this has an impact. If you have one diopter miscalculation, you lose half the 50% of the visual acuity. So if you are able to move that up to 80 or 90%, then you're much better off. And with this forgiveness, you get to that point. The patients where we struggle, even if we are a very experienced surgeon or a very experienced center, are the higher ametropic patients, so the high myopic patient. Just had a patient who got like a +9 diopter EMV, where I did the monovision. And in these patients, even production of the lens has the ISO standard of ±1 diopter. So in these patients, sometimes you are really in a critical phase. And if you have a broader landing zone, like with the EMV, it doesn't matter. This particular patient I had 2 weeks ago with this was perfect. He ended up uncorrected 0.8 to 1.0 in distance, intermediate, and even in near. So we were very happy with this like 1 diopter monovision in this patient, and we really hit the target, even though we are talking about a high myopic patient. High hyperopic patient, post-LASIK patient are other patients that we could consider here. I think the RayOne EMV and the whole system behind it is ideal for every cataract surgeon, even especially those who haven't done any refractive procedures yet, who are kind of in the merge of thinking, do I go with the trifocal lens, who are afraid of creating problems. It's a very safe thing to start with the EMV. First, just do normal ametropia, then monovision, then getting really in the refractive application of this, and this would really put them in a completely different profile compared to what they were first. Then the experienced refractive lens exchange surgeon or presbyopia surgeon will take advantage of the fact that you have no side effects, that with mini monovision you can create a good depth of focus. So it's very competitive to the standard so-called trifocal lenses we have on the market and the emerging EDOF lenses that come more or less every year. So it really is a platform. If you exercise it very much, you can almost use it in any kind of patient.